television program. I'm Dr. David Morwood. I am a
Wait,
board cert.
hang on, Dave. Sorry.
Welcome back to the Doctor is In television program. I'm Dr. David Morwood. I am a board certified plastic surgeon right here in beautiful Monterey, California. Thank you very much for joining us today. In this first segment, I'm going to talk about one of my favorite things during the whole year, during my whole profession, anytime I want to talk about. It's one of my favorite issues to discuss, and that's operating overseas, or operating missions overseas. Just a few weeks ago, I was in Guatemala. Prior to that, I was in Myanmar in Southeast Asia, previously also known as Burma. And a few months before that, I was in Cuba. I think earlier in the year, I got a chance to talk about our trip to Cuba, and then I got a chance to talk about our trip to Myanmar in Southeast Asia. I think today, for this first segment, let's talk about Guatemala. Now, first of all, you may notice something, or you may have recognized something, that all three areas I went to, all three countries I went to this year experienced some sort of humanitarian tragedy or natural disaster, etc. The first country I went to, Cuba, of course, was just a few months after the hurricanes. The Caribbean really got hit hard by the hurricanes, and we went down to Cuba as sort of an informational exchange trip to discuss with those surgeons there in Cuba, how they repair cliff lips and palates, and how they take care of burned hands and burned feet, etc. And we did a lot of operating, and a lot of working with them, operating together, etc. And then the second trip we went on, I came home, of course, back to beautiful Monterey and went back to my practice. The second trip, of course, was to Myanmar. That's in Southeast Asia. And there's currently a problem, kind of a humanitarian crisis with the Rohingya, the Muslim minority there. There was some problems and some fighting and some night attacks, and sooner or later, soon after that, the government ordered the Rohingyas really out of the country. So about 600,000 of them migrated over to Bangladesh. And then I came home, of course, back to beautiful Monterey, and there was a bad volcanic explosion, eruption, I should say, in Guatemala. And a few months after that, we went down to Guatemala City and did a lot of cleft lip and palate repairs. So there's a pattern here. It seems to me that whenever there's a humanitarian crisis or a natural disaster, rightfully so, I think, a lot of the attention turns away from social services for children, cleft lip and palate repairs, and towards natural disaster relief, of course, whether it be after the hurricanes or after the hurricanes in the Caribbean or after the volcanic eruption in Guatemala, or of course the humanitarian crisis with the Rohingya emigration or migration out of the country. A lot of the social services programs turn away from the children, and they are geared towards helping recover from the natural disaster, the hurricanes, etc. So typically these trips I go on this year were sponsored by Rotoplast, which is Rotary International Rotary Plastic Surgery. And the trip to Cuba was sponsored by Plasticos. That's an international humanitarian group based in Southern California around the Newport area in Orange County. And we do similar things along with Alliance for Smiles. We primarily operate on children and babies with cleft lip and cleft palate. We also do some burn work. We do some burned hands. We do some burned feet. We do some simple tumors. We do some congenital anomalies of the hands. And so what happens is, in many of these developing countries, they don't have the same codes that we have here for cooking fires. They have open flames, etc. And oftentimes, the youngsters, the babies, when they're just learning to walk around age 1 or 2, they may be walking around and they stumble and they'll break their fall with their hands. And oftentimes their hands they'll fall into a cooking pit or an open fire and their hands are severely burned. And they grow up with very severe scar contractures, very difficult for them to use their hands. So we do what's called scar contracture release and revisions, and oftentimes they get burned feet. Sometimes they get burned faces and flame burns, etc. But mostly we do burned hands and feet, and of course cleft lips and palates. Now, oftentimes I'm asked, why is it that the developing countries experience more cleft lip and palate? Well, first of all, cleft lip and palate is a congenital difference. It's a congenital anomaly that happens all over the world. The most common incidence is outside of Shanghai, China. Outside of Shanghai, China, 1 out of every 250 babies born has a cleft lip. Think about that for a moment. 1 out of every 250 babies has a cleft, either cleft lip or cleft palate. That's quite a common anomaly. In the western side of South America, about 1 out of 400 babies born has a cleft lip or cleft palate. In Europe and the North American part, the United States and Canada, it's 1 out of every 1,200 babies, which is still a fairly common congenital anomaly. The continent with the least prevalent incidence of cleft lip and cleft palate is Africa. It's about 1 out of every 200,000 births. 1 out of every 2,000 births in Africa. So the incidence or the prevalence of babies being born with cleft lip and palate worldwide is probably about 300,000 babies every year. That's really an incredible number. 300,000 babies born with cleft lip and cleft palate around the globe every year. Now, in the so-called developed countries, in Europe and in North America, in parts of Asia, Australia, etc., the surgeons and medical system, the healthcare system is trained to accommodate these children. Here in the United States, when a baby is born with a complete cleft of the lip and palate, between the age of 3 months and approximately 16 years, the baby will probably get about 4 operations. And they will probably get speech therapy. They'll see an orthodontist, a dentist, speech pathologist, as I said. So the babies here are quite well taken care of and they get timely care for their cleft lip and palate. We don't see babies and children walking around Alvarado Street in Monterey with an unrepaired cleft lip or palate. So sometimes people assume or just consider that cleft lip doesn't happen here in the United States. It actually does happen here in the United States. It's a quite frequently found congenital anomaly. About 1 out of every 1,200 births in the United States and Canada, and in Europe, as I said. Still a very common congenital difference, 1 out of every 1,200 births. So, just to explain the difference between a cleft lip and a cleft palate, I think most of you know what a cleft lip is. Excuse me. Let's start to talk about the cleft lip anomaly and how it occurs. At about day 28 in utero, and as you probably know, on day 28 in utero, that's before most women even know that they're pregnant. On that day, the facial segments are designed to fuse. The frontal nasal process in the embryo rolls forward. That's coming down from the forehead area, accompanying the nose, and what we call the philtral column. That's the central part of the lip. That's the philtrum, and the columns are on each side of the lip. And then the maxillary segments roll from the sides, and they are designed to fuse with that frontal nasal process. Really, they're designed to arrive together within minutes. And if they don't arrive at the same time, or there's some problem with the fusion, then a cleft lip results. Now, a cleft lip can be incomplete. That's when it's just through the lip, perhaps the red part of the lip. We call that the vermilion. Then there's the vermilion cutaneous border, or the white roll. And then there's the skin. And it may extend up into the nose. If it extends up into the nose, it's called a complete cleft lip. If it does not extend up into the nose, it's called an incomplete cleft lip. Now that's separate from a cleft palate. As you know, the roof of the mouth has 2 parts. The very soft, fleshy part way towards the back of the throat. That's called the soft palate. That has the soft palate. That's called the soft palate, and also has that little fleshy little tongue in Latin. It's called a uvula. And that fleshy part of the soft palate is designed to be a flutter valve. And it's designed to go up and touch the back of the throat or the pharynx. And that way, the air distribution in between the mouth and the nose is very finely and carefully regulated when we speak. The other part of the palate, that's the hard roof of the mouth. Now let's think about the anatomy. The roof of the mouth becomes the floor of the nose. I'm going to say that again in a different way. The floor of the nose becomes the roof of the mouth. And when there is a split in that roof of the mouth, when there's a split of the hard palate, that's a cleft of the hard palate. Now, that cleft in the hard palate can extend forward to the ridge that holds the teeth, or from where the teeth erupt. That's a very important structure at the anterior portion of the hard palate. That's the alveolus. Now, a cleft can go through the alveolus, and if that's the case, we need to do a bone graft just before the adult teeth interrupt, sometime between age 5 and 7, maybe around age 6. Just before the permanent adult teeth erupt, we need to do a bone graft to fill in that space. If we do not do a bone graft when there's an alveolar cleft, well, then it's very similar to the keystone missing on a bridge. If you think of the alveolus where the teeth are like a horseshoe shaped and resting on that alveolar ridge, and there's a gap, well, then there can be instability, and the cleft side can shift, the whole bridge or the whole horseshoe can collapse. So what we need to do is restore integrity to that horseshoe-shaped ridge with a bone graft, close the soft tissue over it. That's called an alveolarplasty. And so first thing we do is a bone graft for that alveolarplasty. Now, if we go back and take a look at the cleft lip, in this country, if a baby is born with a complete cleft of the lip and palate, the first operation will likely be at about age 3 months. We like the baby, we have this so-called rule of tens, 10 pounds and 10 grams of hemoglobin, 10 weeks old. So that's at about 3 months, 3 months and 1 week. And so the baby will get a cleft lip repair. At that time, we may do some basic closure of the floor of the nose. We may do a little basic revision of the nose. But essentially, we stay away from the hard palate and the soft palate at that time. Now, why don't we close everything at the same time? Well, it's probably better for the baby's airway. It's probably safer for the baby that we wait just before they're going to start to speak at about 9 months, maybe 10 months or 11 months. At about 10 months or 11 months, maybe 12 months, we're going to close the palate. Now, the reason being for that timing is because it's vital for the baby to have a closed palate when the baby is trying to learn to say some words. Now, as I spoke about previously, briefly, the soft palate serves as a kind of flutter. It's kind of a flutter valve, and it goes up and touches the back of the throat, that's the pharynx, and it carefully, really carefully and precisely divides the airflow between the nose and the mouth. There are certain words in English such as cookie and Coca-Cola where that flutter valve serves as a very important component or driver of speech. If there's a split in that palate or a cleft in the roof of the mouth, well, then the baby can't make a vacuum, it can't close the valve because there's a hole. And so air escapes through the nose, and so a baby will struggle to make some certain sounds, and the speech will never be as good with an open palate, unrepaired palate, as a baby